Hello and welcome to today's webinar, Shockwave Therapy and the Treatment of Neuropathy. This webinar is presented by Zimmer MedizinSystems. I'm Regina West and I'll be the moderator for today's webinar. At any point during the presentation and Q&A, you may submit questions by typing them in the Questions tab on your webinar control panel. Following the presentation, we'll cover all of the questions live, and if there's not enough time remaining for all of the questions, answers to your questions will be emailed to you. Now, Paul Cummings, one of our webinar panelists, will briefly contribute some additional information following today's presentation. And now I'd like to introduce the speaker for today's webinar. We have Dr. Richard A. Schilling standing by. Let's bring him on camera now. Dr. Schilling, will you join us, please?
Hi, Regina. Thank you for having us tonight, or having me tonight.
Hi, Dr. Schilling. How are you this evening?
I'm great, thank you.
All right. I know we have a lot of attendees here anxious to hear your presentation, but before we launch into it, I'm going to give a little bit of background here on Dr. Schilling. With 19 years of dedicated service, Dr. Richard Schilling is a distinguished podiatric physician and surgeon. Holding licensure in Ohio and board certification in foot surgery, Dr. Schilling obtained his doctorate of podiatric medicine from the Ohio College of Podiatric Medicine in 2002. He further honed his expertise through a residency at DePaul Hospital in St. Louis, Missouri, and fellowship training in reconstructive foot and ankle surgery at the Wheel Front Foot and Ankle Institute, Des Plaines, Illinois. Dr. Schilling's areas of specialization include diabetic foot care, sports medicine, reconstructive foot and ankle surgery, and wound care. He's a proud member of the American College of Foot and Ankle Surgeons, the American Podiatric Medical Association, the Ohio Foot and Ankle Medical Association. And residing in Columbus, Ohio with his family, Dr. Schilling is a committed member of his local medical community. And with that, Dr. Schilling, I'll give control of the presentation to you and you can launch right into your presentation.
Thank you, Regina. Okay, I'm going to show my screen here, and then I'm going to start my presentation.
Okay, we see your PowerPoint.
Okay.
And take it away.
All right, thanks, Regina. I appreciate everybody taking the time and effort to be here tonight. It is a, it's a work night, and I get it. I'm working as well. I think, though, this is an incredibly interesting topic. We're going to speak tonight about radial shockwave therapy for the treatment of symptomatic diabetic peripheral neuropathy. But also, I'm going to go into some of the background on shockwave and its history and some of the science behind why this is so effective. Before I get going with the presentation, I do want to thank Zimmer MedizinSystems. I really have been humbled to be able to work with a partner in care, both with my patients and my practice. I feel like the team at Zimmer MedizinSystems has created such a comfortable relationship. I met Paul Cummings a couple of years ago before I purchased my machine, and over time spoke with him and really learned of the science and the benefits behind shockwave therapy. Furthering our relationship, I purchased a machine about 3.5 years ago. It's been an extremely valuable addition to my practice. And somebody that you can work with is very important. And I feel like, if you're thinking about a shockwave system, or you want to, go with some partnered company, it's best to have somebody that you can trust and you can grow with. So with saying that, we're going to move on to the presentation. So objectives for tonight, we're looking to not just talk about the concept of radial shockwave therapy, diabetic peripheral neuropathy treatment, which is sort of a novel use of the radial shockwave therapy. And I want to talk about how it's going to benefit both your practice and your patients. So, the background here, it is important to understand the science, but this isn't necessarily a engineering talk. This is more of a, what are we going to take home from this presentation and how are we going to present this to our patients? I find that when I learn of a new technology or I want to learn more about a technology, I want to kind of have the take-home points that I can package and disseminate to my patients for their comfort and confidence. I find that when I educate patients on a treatment modality, it tends to be much more accepted than if we don't have any of the background information. So shockwave is an acoustic sound wave, and that's a high energy that will carry this energy into the tissue. It's going to promote a regenerative and reparative process for the soft tissues, and it's used generally for subacute and subchronic, but also chronic conditions. This is a projectile energy, and it's an electromagnetic force. It's then transmitted through an applicator into the tissue. I think, unfortunately, a lot of the people out in the audience are maybe thinking of shockwave where it's the extracorporeal shockwave therapy, and this is the older version of shockwave. Not that this is not applicable anymore, but this is just different from what we're going to talk about tonight with radial shockwave. So extracorporeal was, very popular in the 80s and 90s into the 2000s. This was a variety of different treatments used for, this was used for a variety of different chronic conditions. But in 2006, the FDA did approve extracorporeal shockwave therapy for the treatment of plantar fasciitis. The drawbacks were pretty evident early on, but I think that the combination of success with the treatment and safety of the treatment, and frankly, the availability of the treatment being that extracorporeal was the first of these iterations that a lot of folks were using these. The problems were that we're looking at a very painful treatment. So it was under general anesthesia in an operating room. That meant the cost was pretty significant. Scheduling issues, it would take the doctor out of the office. We're looking at injecting anesthetic into the foot and ankle to get them to be comfortable. Once the insurance coverage dwindled for extracorporeal shockwave therapy, we tended to have little options left. And in my area in Central Ohio, there was a technician who purchased a machine, and he would drive this machine around to various offices. The problem was that it still required almost an hour of your time. You're doing a block, then you're coming back in and doing the 30-minute treatment. The cost was significant. The machine rental cost was somewhere in the $600 to $800 range. And I don't know about the practitioners out there, but I'm certainly not going to take less than a machine for my time. So the patient was left with a couple of $1,000 bill for a 30-minute treatment that they're in the office over an hour for. So then further on down in the timeline here, radial shockwave therapy comes out, and radial is more of a sort of a low energy machine, and this low energy was more of a building or a continuous therapy over a number of weeks. And so what we're finding is that these are 5-minute treatments once a week. There is no nerve block or anesthesia required. And the nice part about these is they not only is there no downtime for the patient, I actually encourage the patient to be very active. I want this patient to jam on their foot. I want them to be moving and grooving, because that way they're going to have more of that inflammatory response that I'm going for. It's much more affordable for both the patient and the practice, and published success rates are 75 to 80%. In my own practice, in my hands, anecdotally, I think I'm closer to 90% success rate, but either way, it's a very reasonable treatment option. But I also like the fact that patients can opt for this treatment their first visit. What I try to explain to new practitioners using the radial shockwave therapy is that you want to give the patient options, educate them on their choices, and then if they're interested in shockwave therapy, I would try to do that first visit. This is something where, a patient comes in with their plantar fascial pain or their heel pain. You work them up with your regular evaluation and management, maybe you do a radiograph, and then present them with their options. They can choose either to do nothing about their treatment. They can use their traditional rest, ice, compression, elevation with their anti-inflammatory, whether that's an oral or an injectable, or they can do this shockwave therapy. So I present the pros and the cons of each, and if they're interested in shockwave, I say, well, why don't we start today? I will then close out my evaluation and management note. I'll open up a initial shockwave therapy note, and I'll just do their first treatment that day. Well, what are we doing, and how do you couch that? How do you explain that to your patients? We're creating this micro trauma or inflammatory response, and I liken it to immunotherapy in cancer or something else where we're having the body fight its own battles. I tell the patients that their chronic, senescent, non-healing area is just kind of forgotten about. And what we're doing is we're awakening it to heal itself. We're stimulating blood supply. We're creating neovascularization or new blood vessel formation. And we've got this growth factor signaling that comes in to promote the tissue repair. There's a lot of thought process behind this about the mechanism through growth factors and stem cells, the signals that come in to create this neovascularization or this revascularization that's creating this regeneration of the tissue through the repair of that soft tissue and even bone. I know that when I worked did my fellowship in the Weil Foot and Ankle Institute, Lowell Weil Jr. was the president of the International Shockwave Association at the time, and we were doing a lot of cutting edge shockwave, including for non-union. So this is really a pretty expansile opportunity to treat a lot of conditions. We're blunting nociceptive receptors. This is more of, like I said earlier, radial rather than direct energy. And so we're pushing this energy through the surrounding tissue, and this is accelerating rapidly with this energy, and it's a pressure wave through their tissue. The difference between the enPulse Zimmer Medicine system is that you're looking at a electromagnetic drive system, not a air compression system. The air compression system on the red diagram is a high energy, quick, and it goes away quick. And I think that the downside to that is that it is more painful, but it also doesn't give as much of a long-lasting effect. And I like the lower peak, but the longer duration. It's also a more durable system, has a longer warranty, and I certainly think that the patients tolerate this much better. We talk about indications. I think, again, that for shockwave, you're really looking at your main indications are the plantar fasciitis and Achilles tendinitis. It's not that those other things don't respond well, it's just you just don't see them as often. So when in my practice, the bread and butter is going to be the plantar fasciitis, Achilles tendinitis. You don't want to be injecting Achilles tendons with corticosteroid. And the more we learn about these exogenous injections, the less that I'm really recommending that. I like this more natural approach. I team this with a stretching regimen, some orthotics, and shoe recommendations. But I certainly see a lot of success with Achilles tendinitis and retrocalcaneal bursitis. Not just peroneal tendinitis. I certainly work with the posterior tibial tendon as well. My only caution would be very aware that the bony prominences are uncomfortable, and so I will mark out the kind of the outline of where I want to be with my wand as I'm using it for the treatment. Neuroma has become such a large part of my practice. I just don't like cutting out the neuroma. I find it to be a very aggressive surgery. It seems to be destructive, where I find that they're having humongous relief, really impressive change from the treatment of shockwave or treatment with shockwave for intermetatarsal neuroma. And of course, we're going to speak more detailed about neuropathy, and then certainly a topic I really find near and dear is the wound care. As I am the current chairperson of the Ohio Foot and Ankle Medical Association's wound care seminar, wound care is near and dear to me, and I do plan on presenting some interesting studies and data at our next wound care seminar about Shockwave in wound care. So back to that plantar fasciitis and Achilles tendinitis that I said is probably the most common thing that I treat. I find that it's not just very amenable to this, but these are the most common conditions we see. So, if we're just doing a small percentage of these patients, you're going to really do well in your practice. We're talking about 5-minute treatments once a week. What I do in my practice, and I don't know if this is something that you guys want to emulate, is I tend to put my cash paying patients in a spot where I know that they're going to be on time seen and quickly in and out of my practice. For example, if I have an 8:30 start in the morning, I make sure these people are in at 8:15 or 8 o'clock in the morning, just to get them in and out before even patients start to come in. That way they feel special and they are well taken care of. Remember, we spoke about the Morton's neuroma just shortly. I've seen a lot of results from that. And so what I'll do with those is I'll put the machine directly in the inner space, and I'll put my hand on the dorsal aspect of their foot and make sure that I feel that pulse coming through the intermetatarsal space. Again, you want to avoid the bony prominences like the metatarsal heads. So this is something that it's been a really well tolerated and very effective treatment. So wound care is something that I'm still kind of exploring and getting comfortable with as far as the Shockwave. But if we think about some of the science behind why the Shockwave is helping, we're talking about new blood vessel formation. We're talking about ramping up the body's own inflammatory effects here to heal. And so I think that it's beneficial, and it's certainly not going to harm anybody. I recall when I first got my machine, I mentioned the relationship I have with the company and Paul. Paul had said to me, and he pulled me aside, he said, we really don't have a lot of data on this, and I don't think you should necessarily charge people, but out of the goodness of your heart, if you see somebody who needs a little boost in their healing, a 90-second treatment wouldn't be a bad idea. And so I tend to use this not as often as I should, but I think that I'm going to, like I said, do a little more. That's my next pet project. So this brings me to kind of the background of what we're doing here today with diabetic neuropathy. Between protein biosynthesis and cell proliferation and neuroprotection, these treatments alleviate discomfort and they help with regeneration. So for improving functional outcomes, and we're promoting peripheral nerve regeneration, I think that this is a really exciting new avenue. I didn't find a lot of research on peripheral neuropathy with Shockwave. There was a little bit on post-herpetic neuralgia. There was a little bit on some of the other indications, but certainly not. There's a paucity of research and papers on diabetic peripheral neuropathy treating through Shockwave. So the background here is that we're looking to convert these physical forces into signals that create the development and the like a mechanicotransduction. This is going to improve the effects of these protein synthesis and creating kind of a more healing mechanism. So how did this all start? I was doing a diabetic ulcer patient, and I treated him a handful of times, maybe 3 or 4 visits in a row with good wound care, and the guy healed. Did he heal because of the Shockwave? Did he heal because of my wound care? I'm not really sure, maybe a combination. But a couple of weeks after the treatment, he had contacted my office and he said, Doc, I don't know what you did to my foot, but I can feel my gas pedal again. My first thought was, can't believe you didn't feel your gas pedal, and I didn't know that. That sounds dangerous. But my second was, maybe the light bulb sort of went off, and I thought, well, did the Shockwave create more sensation in his foot? I mean, this guy had a very numb foot. So again, we're talking about neovascularization and bringing oxygen. So why wouldn't that help with the symptomatology of diabetic peripheral neuropathy? That led me to discuss with Paul if anybody uses the machine for this pathology, and he had stated that he didn't think that that was very common. So I went to higher ups with Paul's help into the the folks who run their company, and I made a proposal. I said, what if we did a study on this? I chose 10 patients in a prospective randomized study, and I followed these patients for 1 year after their treatment. Again, prospective randomized study with a control. I created this study because I was looking to get some more information, but I also wanted to see what we could do to help our patients. So I obtained a written consent. The purpose of the study was to investigate the effectiveness of radial shockwave therapy for the treatment of painful diabetic peripheral neuropathy. The patients filled out an initial assessment form on their symptoms and severity, and then a follow-up questionnaire was filled out before each treatment session for a total of 6 treatments. I will say now that that is a little different than when we're doing soft tissues. I normally do 4 or 5 treatments, so it was a different sort of model, but I thought that they would maybe need more treatment because this is generally a more difficult pathology, and for the most part, a more lengthy pathology. They'd had it for a longer time than a lot of the acute treatment or the acute pathologies we do see. These participants agreed to attend 6 weekly sessions over consecutive weeks. I got to tell you guys, I am just floored by the fact that I went through 60 sessions, so 10 patients, 6 sessions each, without one person missing a treatment. I think that tells us a couple things. First of all, it tells us how important treatment of neuropathy is and how much people are seeking help for it. But it also tells us about the bond that is made between a physician and his patients or her patients. And I think how important it is to educate and communicate. If my patients didn't believe in what I was doing, or they had any questions about it, or they were sort of on the fence, they wouldn't have come in. And so I do feel like, and by the way, these patients were not compensated at all. They just got a treatment out of the deal. So I think that that is saying a lot about diabetic neuropathy currently out in the real world. I did randomly choose the foot that we would treat, and that stayed the same throughout the trial. Phone calls were made after the treatment at 4 weeks post-treatment, 3 months post-treatment, 6 months post-treatment, and 1 year post-treatment. This is this is exactly what the questionnaire looked like that I called and asked them each time. And we talked about their symptoms, like burning and tingling, numbness, shooting, balance and coordination, sleep disturbance, but their pain level as well. I would document their ID, which was their initials, and then L or R to designate their treated foot, and the date. So again, 10 patients, they all had diabetes. They all had regular or relatively equal bilateral complaints. So we're looking at people that generally it's a pretty symmetrical problem. 4 women and 6 men. This next point is very important, I feel, because they're all diabetic, but their A1Cs were an average of 6.5. I don't know how I found these people in my practice, because most of my practice has double-digit A1Cs, but you're looking at 5.6 at the lowest and 7.7 at the highest. I mean, that's fantastic. So what that tells me is these are already conscientious people who are taking care of their diabetes themselves. They're doing everything they can to reduce their symptomatic load, yet they still have pain. Study came out a while back that said that even when you control your A1C, it only controls about 10% of the symptomatology on diabetic peripheral neuropathy. So we are looking at a big issue with this. And I think you can read studies that say between 65 and 75% of all diabetics have some form of diabetic peripheral neuropathy. No one regretted trying this treatment, and even those who claimed not to get better would recommend it to a friend, except one of the people, and they still didn't regret trying. All subjects were treated with the Zimmer MedizinSystems enPulsPro radial shockwave therapy, and they were all treated by the same practitioner, that would be me. They all had the same settings, which was 3,000 pulses at 110 millijoules and 10 hertz. We made pain and symptom assessments, like I had said. So I think that this right here on the bottom is a pretty amazing statistic. We had a 35% reduction in pain on a scale of 0 to 10, dropped from a 7.7 to a 5.0, That was the overall average. I'm going to stress that because there was a large divergence, and this divergence in patients started pretty much from the first treatment. Those who got relief really got relief, and those who didn't, they didn't get any relief as far as the symptomatology went. So they usually knew that after the first treatment. That'll play a role in how we will present this to our patients later for their possible treatment modalities in your practice. We're looking at a statistic over here on the scale. On the far left, that's the overall pain level, so 7 to 5. They did have a drop to a 4 at the 6-month interval, and then kind of creep back to the 5. But here in the middle is what I call the responders group, and they dropped from an 8.4 to a 2.2. Now it did creep back up to a 4.8, but that's after 1 year. The treatment hadn't been performed for 12 months at that point. And then you can see that even the non-responders dropped from a 7 to a 5.2. So that was the overall reduction in pain level. And we're looking at a 5-person responder group and a 5-person non-responder group. So when you break them down, and I say that responder versus non-responder because besides pain scale, the non-responder group really didn't see any improvement in their symptomatology, but the responder group did. So you're looking at an overall reduction of 35%, but a tiered reduction. In the responder group, we got 43% improvement of pain. And in the non-responder group, even though they claim not to get improvement, they still dropped to 26% of their pain. We did see in the responder group a reduction in burning, in tingling, sleep disturbance, and overall improvement in balance and stability. So again, breaking it down a little bit further, so the first statistics I was telling you were pain level, so 0 to 10, and now we're talking about specific symptoms. And the reason some of the N's on the bottom, the N number, the patient number on the bottom are not 10 is some people didn't have burning or some people didn't have shooting. All of them had sleep disturbance. And if you look, this is for all 10 patients in my study. So we've got a pretty impressive improvement, even if it's just, if it's including both of these responder and non-responder groups. And we're looking at the take-home point here is that they continued to show improvement and they had long-lasting improvement. Balance was the least affected of all of these symptomatologies, but burning and tingling and numbness and shooting and sleep disturbance all got better. When you start to be a little more detailed in the breakdown, and this is a very telling slide to me, responders, the group of 5 that really showed improvement, we're looking at a shooting pain improvement into the 90s. We're looking at a sleep disturbance improvement. All these are pretty fantastic. Then you look at the non-responder group, and we're looking at all zeros and only 2% improvement in numbness and 2% improvement in sleep. So I think what this tells us is that you'll know pretty quickly whether it's working for you. And if it works for you, it's going to work. And if it doesn't work for you, it's probably not a good treatment for you. So again, the patients who felt improvement continue to feel improvement. I think it's important to stop and say that these weren't done in a vacuum. It wasn't done in isolation. These were all diabetic patients, so they were counseled on a glucose control and preventative lifestyle and behavioral changes. You have to address the underlying causes of neuropathy before you just start treating the effects of neuropathy. So I think I'm pretty comfortable in saying that radial shockwave therapy, along with disease modification or some control of the disease, can be a cost-effective, safe, preventative, and palliative treatment for diabetic peripheral neuropathy. Patients spend a lot of time, a lot of money, a lot of community resources and effort on treatments that are at best helpful and at worst dangerous. These are neuromodulators that have bad side effects and can create other sorts of issues or just treatments that are not helpful. I think that what's important to explain to your patients is that this is not a covered service. that is not necessarily approved by their insurance. But, we're having so many issues with reimbursements, and we're, working harder all the time. It's important to have these cash paying modalities that you can offset the decrease in revenue. So not only do we have this amazing treatment option, but it's good for your practice as well. And, if you go back and look at this graph um, here, you can see that the treatment does last a long time, but they are needing to come back in and again, maybe every 6 months, maybe it's every 3 months. How I present this to my patients is I say, here are your options for diabetic peripheral neuropathy. I tell them about the traditional options, which is, glucose control, B complex supplementation, neuromodulators, antidepressants, tricyclics. Then we talk about shockwave therapy. And I tell them, why don't we do a trial? I'll pick one foot, or you pick one foot. We'll treat it today. We're not going to charge them for the trial. We're going to call that part of our evaluation and management of the day. And then I'll tell them to go home and think about it. I'll say that if you choose to do this, we're going to choose 6 sessions. We're going to do it bilateral, and we're going to do this over the next 6 weeks if you feel like you got any relief from the first treatment. If you didn't get any relief from the first treatment, it's not likely that you're going to get relief down the road. So I don't want them to be upset that they chose something that's not effective. And I certainly don't want a patient doing something on my advice that is not effective. So I would say that for me, it's a great practice builder because these patients are going to come back again and again. So generally they'll buy a package from me instead of a la carte, and I'll do 6 treatments in that package. And then I've had patients who say, well, I'll buy another package, but I don't want to do them 6 in a row. I'll just kind of come in periodically to treat, and I think that's okay. Or you can do them a la carte after that. Just so that we're clear, what I did for my treatment is I would use the applicator and go throughout the whole soft tissue of their body, the entire plantar aspect of the foot. I didn't mess with the PT nerve. I didn't mess with the sural nerve. I didn't do anything proximally. This was all plantar based from heel to base of the toes. I mean, I went everywhere. The only places I didn't push hard would be the metatarsal heads. Otherwise, it was a pretty continuous circle, or kind of a, like a window washing throughout the whole bottom of the foot for the 3,000 pulses. And I'd be happy to get into any more detail about the particulars of the how I did the treatment. And we can also talk about how we do treatments for other pathologies. So back to this cash paying model, it doesn't mean you're stopping to practice medicine. It doesn't mean that you're not doing the traditional things, but we're adding this. And I would also, if you do outsource your billing, I would speak to your billing company and tell them that you're not billing insurance on this, and that you're not going to share your cash revenue with them. Patients are already paying out of pocket. They're paying $50, $60, $80, $100 a copay. Their physical therapy costs them time and effort. I think that these deductibles are so high, some people don't reach them. So offering them something out of pocket, it's not that unusual or that difficult. The way I present it is, this is just another option. If you present unbiased information, you educate your patients, you're partnering with them. I don't really judge people. I don't care if they drive nice cars or have nice purses or phones. People say, well, you pay for that. People pay for what they want to pay for. And the way I look at it is, we're offering a service, and this is an effective service. And you can even say there's studies been done to show the effectiveness of this. And I think that they're looking for options. They're going to spend money somewhere. Why not with you? And whether it's diabetic peripheral neuropathy or it's plantar fasciitis, they're looking for relief. They don't want an injection. They're not looking for surgery. So I think that convenience is also important. I mentioned earlier, capturing that patient in their initial visit when you're talking about these treatment modalities. I would say, okay, we'll start today. And then I also like the idea of carving out a special time for them. First, it's important for them to feel special, but it's also important to get them in and out of the office. I don't like this. I'm not a good salesperson. The reality is, every doctor is a salesperson. You are selling your education, you're selling your plan, you're selling your confidence. And I think that the sooner you realize that that's who you are a salesperson. And I think that people will learn, or you'll get more comfortable. But I find for me that I'm very passionate about this because I know it works. Once you get comfortable with the effects and the outcomes, I think you'll find it pretty easy to sell, because you're saying, look, this is a very effective treatment, and you can give them some background or science about why it works, and it's a nice addition to your practice. You know, have to ask. If you don't ask, you'll never know. So again, like I said, I present unbiased, you know, kind of a option packages to patients. You know, we can do nothing. We can do the traditional care, or we can do this new treatment modality, which is, I tell them, it's a paradigm shift. We're thinking outside the box. You know, we're going from stamping out inflammation and creating, you know, this senescence and this you know, non-weight bearing and ice and rest and all these things, versus trying to ramp up the inflammation to have the body heal itself. And so I think patients want a natural approach, and I really like Shockwave because it offers them that option. So one patient per month, that's generally all you need to cover the payment, and then you're likely still going to have a profit after that. But it's really not that difficult to find one patient a month to do this. And I think that that's pretty simple. I do a pretty heavy Medicare Medicaid practice. I work in a hospital setting often, at least a medical office building on a hospital campus. So I'm not in an affluent area. I don't have an affluent patient base. These people figure out a way, whether it's their parent or their kid or their friend, or they tell you, you know, listen, doc, I'm going to have to make some payments. You know, I think that that's up to you and how you handle that in your practice. But if you're seeing, you know, 30 patients a month with plantar fasciitis, Achilles tendinitis, neuromas, neuropathy, all you have to do is just a handful of these patients, 10% or 3 patients per month, you know, whether they don't want an injection or they're looking to, you know, kind of not have to do the physical therapy side of things. They don't want to stop their life. Like I mentioned with soft tissue treatments, I want them to be as active as possible. And then maybe they've tried everything else and they just don't want surgery. So again, I think that what I like about Shockwave is we're looking at effectiveness, safety, and really win-win for you and your patients. So I'm going to end there until the question and answer time. I'm going to hand over to Paul Cummings. Paul's been, like I said, a partner in my practice care, and I'll have him take over until I'm needed. So thank you, everybody, for allowing me to speak to you tonight about a passion project of mine. And I'm going to mute and turn off my camera.
Wonderful. Thank you so much for that presentation, Dr. Schilling. What a fascinating study, and such incredible results he received. Hi, Paul.
Gina, how are you?
I'm good, thank you. So Paul is, this is Paul Cummings. He'd like to say a few words now before we get to the Q&A section. And by the way, just a reminder to attendees, you can continue to submit questions at any time during the presentation, during the webinar. There are a lot of questions coming in, but first let's have a few words. We'll see Dr. Schilling back in a couple of minutes. A few words from Paul. He is the Zimmer MedizinSystems specialist in enPulsPro for podiatry and sports medicine. Paul, take it away.
Thank you, Regina, and thank you, Dr. Schilling, and thank you all for your time. I'll be very brief because I know you didn't come here to listen to me. So basically, I'm just going to go over what Dr. Schilling said and continue where he left off and talk about how this fits into your practice and how affordable it really is. If you were offered a free Shockwave system for your office, would you take it? I assume the answer of most of you would be yes. Would you use it? Would you put it on your website? Would you treat patients with it? If it was free, you'd say, sure. There is a catch, of course, and the catch is you have to treat one patient per month in order to make it free. Based on the system cost on the monthly payment and what the revenue is, one patient. Keep in mind, this isn't technology you have to bring onto your practice where you have to treat 10 patients to break even, one, and you're making a profit. So as far as a financial commitment or a risk to the practice, it's very, very low. Like I said, average revenue is $500 to $600 per patient for an average of 4 to 5 treatments. Monthly payment for the enPulsPro system is $379 per month with no payments for the first 6 months. So again, one $500 patient, you're making your payment, and you're still making $121 profit, if my math is correct. You're not killing it, you know, but payments made, you're getting all those benefits of putting it on your website, marketing, using it. you're making a profit, you're sleeping well at night, there's no stress. Obviously, that's not your goal to treat one patient per month, but we'll help you do more than that. One patient per week is $2,000 a month in new revenue, which is $24,000 a year. Yes, shock face. Very easy to do. Like Dr. Schilling said, if you treat 10% of the patients you see on a monthly basis, which I'm sure is a lot for most of you, it's a minimal number. What else does that one patient get me? Enables you to add the modality to your website and promote new technology to potential patients. That one patient gives you the ability to compete with other practices in your area. This is important, kind of going to the next slide too, next bullet point, is that patients, consumers, people are on Google for everything. So if they're looking for a doctor in your area, your city, your town, and they find one practice and they click on the services menu and it says we offer this, and a whole bunch of modalities, and then you go to yours, respectfully, they click on one, it says custom orthotics. It says something. So most patients say, you know what, I think I'm gonna go to that practice if they seem a little more current. They seem like a little bit more with the times. So don't lose patients to other practices that offer more when you can bring on something like this that's very affordable and easy and makes you competitive with other offices. You don't have to figure it out on your own. This is certainly not, here's your system, good luck, thanks for the sale. We're gonna work with you and give you all the tools you need to succeed. We're gonna train you on not only how to use the system, but how to present it also, which is huge. Not too many other companies do that. This includes what to say, what not to say, how to overcome objections. Paul, what do I do if a patient keeps saying this? You're gonna call us, you're gonna say, yeah, I'm gonna give you some responses from your perspective, not from a sales perspective. And we'll just teach you the unofficial rule book of what to do. It's your 30-second elevator pitch. You're not spending 20 minutes talking to patients trying to convince them. It's 30 seconds, that's all you have to do. Some patients may say no, most will say yes, but you don't have to become, like Dr. Schilling said, I'm not a good salesperson, you don't have to be. You receive all the patient forms, consult forms, consent forms, marketing packages, digital images, patient video for your website, a stand-up banner for your waiting room, which draws attention to most patients sitting there. This is what we've done for other practices. Unlike brochures, patients can't miss this. They're sitting in your waiting room doing nothing, they're all looking around. They see this, it's a quick message. By the time they get into your room, you talk to them, they say, what's that thing I saw outside? Shockwave therapy, and then you take it from there. But again, we'll help you with everything you need to make this successful for your practice. And that's it for me. Thank you. And Dr. Schilling's going to come back on and answer all your questions, which are probably more important than what I just went through. But thank you again.
Thanks. Thank you, Paul. Excellent. And Dr. Schilling, thank you for coming.
Thank you, Paul.
Back.
Thanks, Regina. Let me just say one more thing. I really take advantage of these things. If you look on my website, abcpodiatry.com, you can see what Paul's talking about. I used the information they gave us, and then I have a beautiful banner that he customized for my practice. For example, I personally think that saying something like pulse wave therapy is a little kinder, a little less aggressive, and so I asked them if he could put pulse wave therapy in my office. So they accommodated me on that. Brochures, anything I need, I know I can go to him. Occasionally I'll ask about a setting or something, but I just find, like I said early on, you want to partner with a company that's going to want you to succeed.
All right, great. So are you ready to answer some questions?
Absolutely.
All right, fantastic. And Paul will also hang out during Q&A. He may be able to field some questions as well. So the first question, Dr. Schilling, is you mentioned 75 to 80% success rate, and you said during your presentation that personally in your practice you experience more like 90% success. Yes. The question is, the 75% to 80% success rate, is it based solely on this treatment modality being used to treat plantar fasciitis?
No, it's never an isolated treatment. As a matter of fact, I think that more practice management or more practice building, I will package these with medical grade orthotics and then give a discount on the medical grade orthotic cost to the patient as a thank you, or as a, you know, kind of like a partnering in care. So these plantar fasciitis patients are doing stretching, they're doing medical grade orthotics or custom made orthotics. I will ask them to not do ice. I will ask them to not do anti-inflammatories, and I will ask them to not rest. The whole point of Shockwave, or in my practice, PulseWave, is that I want the inflammation. I'm looking for that activity in the tissue. And so, yes, I want them to stretch. Yes, I want them to wear their inserts. But other than that, they're active. And I find that runners and sports people really like that idea. They don't want to take time off, and they don't have to with Shockwave.
Okay, that was one of the questions here. Somebody else asked, do you advise no icing, no anti-inflammatories while
Correct.
doing the treatment? And if so, how long? For how
So
long?
during the treatment, and then I ask them for at least a week or two after the last treatment to stay that way, to give it some long-lasting effects. And I'll tell you that Paul and his team also helped me with a consent form that explains a lot of these things that they can initial and explain, and they can have a copy of. But then I'll tell you something else, a little bit off topic, but in my ancient days in residency, when we were doing a ton of these things, I did a really poorly constructed retrospective study that showed that Shockwave kept working after the treatment ended for up to 1 year. Now, again, that was extracorporeal Shockwave, and that was back in 2001. But the reality is that I think that some of the principles still remain the same. That I'll talk to patients, and I'll generally do their treatments 1 week in a row, like I said, 5 weeks in a row, one treatment apiece, and then I'll have them back 4 weeks later for an E&M visit. During that E&M visit, I'll ask them how they are, and they'll tell me they're, significantly better than even after their last treatment. I will tell you something else, practice building. At that evaluation and management visit, if they require one more, if they say, I'm so close, I feel like I'm 85%, I'm 90% better, I'll give them a 6-1 for free. And my thought process is I'm already coding it as a 99213 or 214, depending on how much time I spend with them and the complexity of the level that I'm at. So I figure, you know what, it's again, I'm partnering with the patient in care. I hope that answers that question.
So you are coding the treatments then?
Not the ones they pay for.
Ah, okay.
So okay, for an example, you're a new patient, so there's a 99203 or 204, depending on what we're doing. Then you get your x-ray, your 73630, and then we're going to talk. After we talk, if you decide to do this, I close out that visit because that's a separate evaluation and management. And then I go into a cash treatment for the next 5 weeks. There's no copays, there's no deductible, there's no cost except the upfront money for the treatment. And then I say, I want to see you in 4 weeks for a formal visit to talk about this. That's the evaluation and management visit. And I feel like at that visit, if I want to pop a treatment in there, I can. Now, if they call and say, you know what, I want to buy another set or I want to do more, that's a whole different story. But I will offer that as an option.
Okay. Apologies, these questions, there are plenty of questions here
Good.
from the attendees, but they're going to be bouncing all over the place from your study back to your protocols. So the next question regarding your study, were the treatments during your study free for the patients?
Yes, they were not charged and they didn't get compensated. So they were asked to do this treatment, and their quote unquote compensation was the treatment. And so these were all patients of mine. They weren't new. They were all current patients that were struggling. And I didn't pick them like a cherry pick. I did the first 10 people that said yes. And frankly, as a one-man team, I had to do them in sections because it was a very large undertaking. So I would do 3 or 4 at a time, get through most of their treatments, and add a couple more, and I staggered them throughout.
Okay. Can you detail how exactly you performed the treatment on the area?
Yeah. So if this is the plantar surface of the foot, and I have the wand, I really would just kind of go around and around in concentric circles. I would do passes all throughout the area. I even went to sometimes the toes, and I kind of gave them this circular motion. Really, there was no it wasn't like there was some sort of rhyme or reason. I just made sure I covered all the area continuously throughout the treatment while I'm holding the wand with a firm pressure. I will say this, that in my practice, I tried to train my staff to do this, but some of the patients were having less success. And so I took it back over because I find that the staff is scared to press hard and they don't want to hurt people. And I'm not I don't like hurting people, but I know I'm helping them. And so I often will press extremely hard, as much as they can handle, telling them that the first 30 seconds or so, the first 500 pulses are a little uncomfortable. It's not pain. It's just they're a little bit uncomfortable. And as soon as that passes, that nociceptive receptor is overwhelmed. It gets kind of a numb-like feeling, and they feel so much better. And I will say, I do warn them that oftentimes they'll have a red or an erythematous area down there. And I say, that's what I'm looking for. I want that. That's blood flow.
Okay, there are a lot of settings here, questions on settings and also pricing. So we'll do one about settings.
Sure.
Are your power and frequency settings the same as for plantar fasciitis treatments? And I
No.
assume no.
No. So one of the advantages of working with Zimmer and Paul is he gave me a cheat sheet. And I don't know about other people, but I taped it into the inside of my machine. Every time I open my machine, it's right there. And it says neuroma, peroneal tendinitis, plantar fasciitis, Achilles tendinitis. And for me, I memorized most of those, but the reality is I don't have to. They're right on the machine, inside the machine. So it's not like obvious. But for plantar fasciitis, it's 3,200 pulses, 120 millijoules, and 12 hertz. But for my study, I dropped it down to 3,000 pulses at 110 millijoules and 10 hertz. So, we came up with these settings based on a number of comparisons between my neuroma treatments and my soft tissue injury treatments. So it was pretty arbitrary, to be honest, because there's not a lot of data on that.
Okay, Paul, you may want to jump in on this one as well. I'm sure you both might have some commentary here. Someone asks, I struggle with getting patients to pay cash, which is why I'm hesitant. How do you sell this treatment?
Before Paul does, I'll tell you my way.
Okay.
Education. Spend time with them. I say, look, you can do what you want to do. And my favorite thing to say is, if you have an infection, a broken bone, or a cancerous lesion, I'm in charge. I will tell you what to do, and that's what we're doing. But if you have something that's a soft tissue injury and you want to live with it, you can live with it. So I'll tell folks, we bookend things. One end of the book is benign neglect, nothing. And the other end is surgical intervention. Between there lies what you want. And so we'll talk about, I'll first say the traditional approach is rest, ice, compression, elevation, anti-inflammatory of some manner, injection, pill, whatever you choose, and some stretching exercises. If you like that, we can do that. But if you're into something different and you want to try something new, and then I go into how Shockwave will eliminate or treat their discomfort, talking about the neovascularization, the anti-inflammatory effect or the pro-inflammatory effects of the machine. And then I got to tell you, there's so many people out there looking for a more natural approach. And I definitely think that we're moving away from oral meds and injectable meds. They like the topical ideas. They like this option. Paul?
Yeah, that's exactly well put. Basically, I try to explain to when you talk to the patients, try to really hone in on the convenience aspect of it, the quickness, the efficacy, but it's convenience. Once a week for 5 minutes. Just like you mentioned before, do you want to go to physical therapy for 2 to 3 times a week for 6 weeks for an hour each time? Most patients say, no, I don't have the time for that. Plus your expensive copays. Yeah, that sounds awful. Great, we have Shockwave once a week, 5 minutes. Do you want a steroid injection? Not really. To be honest with you, I'm terrified of needles or I'm allistic, whatever it may be. Great, we have this option for you. You don't need injections. Do you ever want to wear a night splint to bed? A lot of my patients say they toss and turn. It's uncomfortable for a month. But if sleep's not important to you, you can go with that. Well, that sounds awful. What else do you have? Great, glad yes, we have Shockwave therapy. So it's just a matter of how it's positioned. Like I said earlier, you don't have to get into a 20-minute conversation with your patients. Just like you said, it's just quick, giving them the benefits of it. This is why you should do it, and that's it. I mean, it's I'm not trying to oversimplify it, but it's not that difficult. Even if you say, oh, I'm terrible, I don't know how to do it, don't worry about it. We'll give you the script just enough to say, what to say to patients.
Yeah.
I agree with Paul. Don't get in the weeds about electromagnetics and acoustics, and that's not what they care about. They want to know, is this safe? Yes. Are there any side effects? No. And you can keep going.
And one last thing I want to add too, I always try to stress to get as much of your staff involved as possible. So when patients are sitting in the waiting room, they see that banner, they're thinking to themselves, what is that? If they check in the front desk, and if by chance someone says, oh, I can't wait to see the doctor, my foot's been killing me, have the person at the front desk say, oh, ask about shockwave therapy, it's great. Don't say anything else, that's it. So it's almost like, okay, now they hear that, they see the banner, by the time they get to you, like, what is everything, what is this I keep hearing about? So the more the staff is involved, the more the staff can talk to patients. They may come in like, oh, I love Jenny, she's great. Then great, get Jenny involved. Have Jenny mention shockwave therapy. They may listen to her and say, Jenny said I should do it. So the more people involved, the better.
Agreed.
Great point. All right, so you mentioned, Paul, I believe you mentioned steroid injections. So one of the questions is, can you use steroid injections in combination with this treatment?
I mean, you could do anything you want, but it's counteractive, and it doesn't make a lot of sense. If you choose one, you choose one. If you choose the other, choose the other. I would say with a qualified no. It's not that you can't, but it just doesn't make a lot of sense, nor is it really effective. So what you're doing is you're going to put all this anti-inflammatory medicine inside, and then you're going to inflame it like crazy. It just doesn't make a lot of sense. So I would say don't do that.
Okay. There's another question about using shockwave in combination with PRP therapy. What do you say about that?
I got to say I don't have any experience, so I'm not going to sit here and tell you yes or no.
Paul?
I've done PRP, but I won't say I've done it with or without shockwave. It sounds pretty reasonable, but again, now you're asking for two cash pay treatments. If my anecdotal success rate was lower, maybe that sounds like a good option. But having an 80 to 90% success rate with your shockwave, why do you need to introduce yet another modality? Plus, now you're asking for some possible side effects or issues. Certainly, infection could be a possibility. Now you have an uncomfortable injection on top of this. So to me, that just doesn't make a lot of sense. I'm not saying don't do it, but I would. Again, you don't want the shotgun approach of put a bunch of things at it. I would rather try the shockwave, and if it's not effective, then you could always go back to a PRP or vice versa.
There was another question. I'm not finding exactly how it was worded, but it was about basically, is the shockwave the first thing that you offer a patient, or do you try other treatments first and then come to this?
That's a great question. I think the answer is yes, both. The reality is, again, like I said, a new patient comes in, you present them with all the options. Some people say, look, I'm going to try stretching and I'll take a mental dose pack and, I'll wear your inserts for 2 weeks and we'll see where we're at. And if it's no better, I'll do the shockwave. Some people say, I'll do the shockwave first. And if it's no better, I'll do the injection after. I don't think there's a right way or wrong way to do it. I think it's about patient comfort. Like I said earlier, there's only 3 times I tell the patient what to do: broken bone, infection, or fracture, or cancerous lesion. So as long as they don't have anything life-threatening or functionally threatening, there's no wrong answer.
If I could just jump in on just briefly, this has happened several times where we've had practices that offer all conservative treatments first, and it's gone 5 or 6 weeks, they've failed, and they say, okay, let's try shockwave therapy, and it worked great. And the patient said to the doctor, why didn't you let me know about this 6 weeks ago? And I could have been done with this already. So in my opinion, it's the very first visit you say, here are your options, and you always let them know shockwave therapy is an option on visit 1.
You know what? Thank you for saying that, because that happened to me before. When I first got it, I think a lot of people get, like, I don't want to say nervous, but you're gun shy, and you wait for like a failure before you offer it. And that exact thing happened to me, Paul. And then I said to myself, why am I not telling them about it first thing? That way, at least I put the bug in their ear. Oftentimes, and this happened exactly 1 week ago, a new patient came in, plantar fasciitis. I gave her all her options. She said, I'd like to do the shockwave. And we did it that day. We started it. Today was her second visit, because that was 1 week ago. She told me she was significantly improved, and she's very happy she did this. Oh, and by the way, she's an older person who told me she is a farm girl who doesn't wear shoes, and she didn't have any use for inserts because she doesn't wear shoes at all, which
Makes sense.
not, but again, it's not what I tell folks. Barefoot is really bad for plantar fasciitis, but yet again, she wanted to do it. I wasn't going to argue with her.
But the treatment still works.
Correct. She was very happy.
Okay, there are so many questions. We usually try to keep these webinars to about an hour, but there really are a lot of questions we haven't even we haven't even touched on. Would you be willing to give us 10
Yes.
more, 15 more minutes at most?
Yeah, I
Okay.
mean, I like the interest because this is something that I really believe in. And so
Yeah.
for me, I'm passionate about kind of disseminating this and teaching others. It's really good for your patients, and it's really good for the docs to continue to be able to be profitable, but also to offer safe and effective treatments. To me, this is just a win-win.
Okay, great. So we'll just take some more
Fire.
questions until we get tired, I guess.
All right,
Okay.
fire away.
So there are a few on cost of treatment, what you're charging. So I'm going to combine a few
Okay.
questions here. One person asks, what are you charging for BL neuropathy treatments? And for reference, they are charging $500 for a single foot plantar fasciitis. That's for reference. And then another person asks, what do you charge? Do you charge per session or for a 6-session set? How many sessions do you
Great.
usually
These are great questions.
do for
So
usage?
I'm in a pretty average area, in, Columbus, Ohio, and I do $500 packages for plantar fasciitis or Achilles tendinitis or neuroma. That includes 5 treatments if they pay the package treatment. Otherwise, it's $150 a treatment. For neuropathy, though, since it's a bilateral and it's 6 treatments, I do ask for $800. My thought process is I'm not charging them $1,000, which is $500 a foot, and I'm doing 6 treatments. So it is, I know it is more, but we're going to be together a lot longer. And your time is your money. If they don't want it, they don't have to do it. You're not making people do this. My neuropathy treatment, um, I guess the people who do neuropathy treatment through me, it's certainly lower than the amount that do plantar fasciitis and their other symptomatology or pathologies at this point. Now, maybe that'll change as the confidence of the study behind me with all these numbers and be able to tell people. But again, let's go back to a couple of simple points. Trial the neuropathy because people will know right away if it's effective. And second, I like to have the machine ready to look at, to touch, and to feel and to hear. That takes away a lot of anxiety from people because then they can go, oh, that wasn't so bad. And even before a treatment, I will have them touch it with their hand. I'll put it in the soft spot. I'll just have them listen to it and feel it. And they'll go, all right, I can handle that. But then I'll warn them. I'll say, look, that spot's not your tender spot. I'm going to be doing a tender spot. And I'll warn them the first, couple hundred pulses will be mildly uncomfortable and not much more than mildly.
Okay, next question, any downtime post-treatment?
None. And that's what's beautiful about this. It's the opposite. You want people to jam on this. For neuropathy, it doesn't make a difference whether they rest or don't rest. And frankly, most of my neuropathy patients are older and they're more sedentary or they're more, they're not going to be out there running marathons. But all my acute injury or chronic injury patients, like the plantar fasciitis, the basketball player with Achilles tendinitis, I want them to be active, but I also want them to stretch.
Okay, I have a couple questions, Paul, that you might be able to jump in on here and join in. You may have some expertise here. Number one, there's a couple questions for you, Paul. Is there any patient-friendly brochure to give the patient so they can go home and Google the technology or the treatment?
That's a loaded question. We do have brochures to give patients. I usually suggest to never recommend having a patient go home and Google anything. You're opening up Pandora's box. I've had practices and doctors say, well, can you give me some studies to hand out to patients? It's a terrible idea. You don't hand out studies to say, here's orthotics, here's the studies on how well they work. This is the same thing. So the quick answer is yes, we give you brochures, just enough to answer the basic question of patients. You have posters, the stand-up banner. That being said, if you want something specific, we'll create it for you.
And for me, I find that my website's a great resource for them. So I'll have them go to my website and, Paul and the team have given a really great, Regina, can I share my screen?
Sure. Give
How
me
do I
one
do that?
to make you presenter again.
Okay. I just want to show the folks something on there we go. Okay, show my screen. All right, so what you're looking at here is you're looking at my website, and the first thing it says on the top here is radial pulse wave therapy. And again, I say pulse wave in my office, and it had we offer. And then you click on here, and it's got this wonderful explanation about this. It's got the picture of the machine. It's got how it works, how is it performed, why you consider it. So again, this is really fantastic information here on the bottom. No, it is not covered by insurance plans. So thanks, Regina. I don't need that
We have
anymore.
to give you the new video link.
All right, excellent. We'll have to do that. But I'm just, again, I feel so comfortable in offering this treatment to patients because it's been extremely successful. And I think the more you do it, the more comfort you get with it. And it's like anything else. You'll sell what you believe. And I believe in this. And so for me, this is something where it's just been a real benefit to my patients and my practice.
Okay. Here's a question probably for both of you. What is the difference between radial and focused shockwave therapy?
You know, it's about depth of tissue and it's about focus. And so just like it says, that focus beam goes so direct into that area and it's very strong. The radial gets into the tissue. And what I tell patients is, so I'll find like the plantar medial calcaneal tubercle for their plantar fasciitis, but then I'll mark along the medial band of their plantar fascia where they're having pain medially, laterally, all along. And then I'll take the wand and I'll go up and down and around because I'll tell them I'm recruiting neovascularization. I'm trying to get the blood vessels to come in to heal the area and to bring those growth factors. Paul, do you have anything to add to that?
Typically, the focus shockwaves are because of the depth of penetration, they're usually beneficial in treating non-union stress fractures. Studies show, and I'm being very honest here, when you use a focused or radial system for treating soft tissue tendinopathy, plantar fasciitis, Achilles tendinitis, there's really no difference in efficacy. The focus units are about 3 to 4 times more than the radial units. But if that being said, you say we see a ton of non-unions and stress fractures, then focus is probably the way to go. If you say no, we see 90% of soft tissue, and we're going to be using this modality for just plantar fasciitis and all those conditions, I don't think you need to invest the money in a focus system. And to let you know, Zimmer MedizinSystems does make a focus system.
And furthermore, the discomfort involved with the focus systems is significant. I can still recall that one of the last ones I did a PT block, I did a sural block, I did an ankle block, and she still was in extreme discomfort throughout the whole procedure.
Okay, here's an interesting question. Are you doing an epidermal nerve fiber density biopsy before treatment? No.
No, this is all based on subjectives. You know, I mean, the honest answer is, okay, so if the epidermal nerve fiber density test came out negative, do they still have symptoms? Yes. So to me, I'm not claiming to cure neuropathy. I didn't tell them I'm regrowing their nerves. In the beginning, this was about symptomatology. And the reality is that almost all therapies at this point for neuropathy are palliative. And so I'm not sitting here trying to prove that the nerve has regrown. I just want the patient to be happy. And in this particular case, I proved that they are happy when it works.
Okay, and I assume your answer for this one is also no. Do you get MRI prior to making sure no tear? Prior to make sure no tear.
For soft tissues? Yeah, I mean, not every time, but yeah. I don't think that's a bad idea. Now, not for plantar fasciitis. I don't remember the last time I would ever do that. But if we're talking about a peroneal tendon or a PT tendon, yes, I will, because I'll tell them, look, this isn't going to work if it's torn. You know, but if you've gotten an MRI and they don't want surgery or they don't want, you know, they're not looking for injections at that point, and we're not injecting into Achilles anyway. So yeah, I would say for the most part for the tendinopathies, yes, I am getting an MRI. Not every time, but most times.
Okay, how does enPulsPro handle treatment customization for different patient needs, particularly in diabetic foot care?
Well, the enPulsPro has settings that you can change for whatever you want, depending on what you're treating. And like I said, settings, you can adjust however you want, but there's guidelines that you're given or you could ask for, and we would share, I would share, Paul would share. We're on the same team. We all just want to make patients happier. So yes, it's very adjustable. It's very customizable. Yeah, yes is the answer.
Okay.
You can preset favorites on the screens too. So if you want to set certain energy levels or conditions for certain conditions, you just list them all and touch it and the screen just sets.
So you can save your favorite treatment setting.
Yeah.
Okay, great.
Fasciitis, Achilles tendinitis, neuromas, whatever you want. So when you turn it on, it's in the favorites menu.
Easy as the touch of the screen. That's nice. Okay, so this is kind of a maybe 4-part question here from one, but they're all related. It's quick
Four
answers.
parts.
What article do you recommend I read to educate myself? This is coming from a practitioner. Any contraindications? Do you use anesthesia? How painful is the procedure? So we can take it one at a time
Okay.
if you.
Unfortunately, there's not a lot of data on neuropathy. There just isn't. As far as plantar fasciitis, you know, I don't necessarily have a go-to. I think that Gerdes has put out a lot of information, so anything he's written, I generally enjoy. I think he's a really fantastic resource, Luger. I think as far as anesthesia, zero, none. You don't want that. You want them to be able to tell you where they're feeling it. Oftentimes when I'm using the device, I'm looking for that specific extra painful spot. Pain afterwards, zero. What was the fourth part?
Contraindication.
Oh, none. Tear. Or open skin. I mean, I don't want to be doing it on open skin. I'm not looking to do it on anything that's a tear in a tendon or a ligament. Certainly that's not going to help. So pretty much there's really not a lot of contraindications.
The only one we really kind of focus on is the is blood thinners. It's a rare, something that's going to happen is very rare, but that's what we usually tell our users.
I haven't seen that. I've used this machine for about 3.5 years, and I have not seen that. I'm not telling you that you shouldn't be careful, but that's not something that's been an issue for me.
So you mentioned wound care a moment ago, and this is more of a comment than a question. I've been using it on my wounds. It has been helping close wounds faster for sure. 60 millijoules, 10 hertz, 500 pulses. Does that sound like about right?
Yeah, I mean, again, I think that's on the lower end of the energy. I think I'm at 90. Is that right, Paul? You told me the settings. It's on my
It's
machine.
usually, for wound care, it's usually around 70 to 80 millijoules at about 800 pulses.
Yeah.
Like
It's like 90 seconds.
The wound and angle in, like almost spiral, like stay on the outside and angle in. Don't actually go
Yeah.
on the wound.
I would say for wounds, for me, how I do it is I do my debridement, I cleanse, I do my debridement, I dress it. Now I've got the wound covered, usually with not only gauze, but I use like either a Copan or an Elasticon to get enough absorption of the energy, and then I'll just go right around the wound and then even over the wound a little bit during the treatment.
Around the wound, so not on the wound itself. You're going on.
No, I do that too. I do.
Oh.
I mean, again, I'm looking at this as a safe treatment option that if it's going to break up the tissue and it's going to energize the tissue, I want it to be in and around my wound.
Okay, I have to be honest, there are tons and tons of questions here. We'll never be able to get to them. Really fascinating topic, Dr. Schilling. I don't want to keep you here all night. You promised me an extra 10, 15 minutes and I've taken it. So I just want to say thank you so much. What a fascinating presentation and the Q&A, both Paul and Dr. Schilling. Thank you so much for hanging in here and offering for the discussion.
All right, thank you. And
all right.
I mean, if you want to send me a list, we can maybe even send it out to the attendees. Yes. That's reasonable.
Yeah, we'll definitely get all of the questions answered via email, and Paul will do some follow-up.
And if anybody on the call wants to give me a call or an email or a text, I really don't mind. I love talking about this stuff. It's a passion project of mine. Just reach out to Paul or Regina. They know how to get a hold of me. Or if you know me personally, please come by and talk to me. I also will be at the Ohio Foot and Ankle Medical Association annual seminar in 2 weeks. So if you're here in Columbus, we'll be happy to see you.
Excellent. That would be a great opportunity for people to come with their follow-up questions. But as we mentioned, we'll get your questions answered following the webinar. Thank you so much again, gentlemen. And I will just share one last screen with the attendees. If anyone would like more information about the enPulsPro, please visit Zimmer MedizinSystems website at www.zimmerusa.com and navigate to the enPulsPro Radial Shockwave Therapy section of the website. Zimmer MedizinSystems also has an assortment of waiting room materials available for you to browse on the shopping site at shop.zimmerusa.com. If you'd like to speak with Dr. Schilling or Paul Cummings directly, please send an email to info@zimmerusa.com to be connected with them. And this concludes today's webinar. Thank you so much for attending. A recorded version of this webinar will be emailed to all attendees so that you may review any of the information at your leisure. Good night.